Imagine your body, this incredibly complex machine, suddenly just hitting a wall. Not like a direct attack, but this internal crisis where it's simply not getting enough of what it needs.
Yeah, not enough to survive.
Exactly. We're talking about this hidden struggle, a silent emergency where your vital organs are literally starving for oxygen. Welcome to the deep dive. Today, we're plunging into the urgent, often life or death world of clinical shock syndromes.
A really critical topic.
It is. Our mission is to kind of become medical detectives,
Yeah.
Understanding the subtle clues each type of shock leaves behind so you can grasp what it truly is, how we distinguish its different forms, and, crucially, the immediate steps taken to manage it. This isn't just medical jargon. It's life-saving knowledge pulled from the sources we've gathered.
And understanding these nuances is absolutely critical. In cases of shock, prompt recognition and immediate targeted action are just paramount.
Every minute counts, right?
Every single minute truly counts. Because if it's left unchecked, shock can quickly lead to, well, irreversible damage, severe organ failure, and ultimately it can be fatal.
Okay, let's unpack this then. When we talk about shock, what exactly is it beyond just someone looking, terribly unwell? It sounds simple, maybe, but it feels like a really profound physiological crisis.
It's a fundamental breakdown, really. At its core, shock is a critical condition where your vital organs just fail to receive enough blood flow.
Like a power outage for the body.
That's a great analogy. A citywide power outage for your tissues, they're not getting enough oxygen, and that shuts down how your cells function, leading eventually to organ dysfunction. And here's a really crucial point. Shock isn't just about having low blood pressure.
Oh, that's interesting. Why not?
Well, your body is incredibly clever. It has these immediate built-in compensatory responses, like your fight or flight system kicking in. These can temporarily keep blood pressure looking normal even when there's a serious underlying problem, say, massive internal bleeding. Yeah, so that's why you absolutely can't rely on just one vital sign. It can be misleading.
So someone could be in really serious trouble, but their blood pressure could initially look deceptively fine.
Yeah.
That's a critical distinction. Easily missed, I imagine.
Very easily missed without understanding the full picture.
Okay. Our sources tell us that while these conditions can sometimes overlap, doctors traditionally classify shock into 5 broad categories. It seems like a helpful way to start untangling things in an emergency.
It is. It provides a framework.
So here's where it gets really fascinating for me. How do medical teams actually untangle these different types of shock when the initial signs might seem kind of similar? Because knowing the why behind the shock drastically changes the how for treatment, doesn't it?
Absolutely. It's night and day sometimes. Each type of shock has a distinct primary cause, a unique hemodynamic profile, which is essentially, how blood is flowing and being pumped and specific clinical signs you'd look for.
Okay, where should we start?
Let's start with hypovolemic shock.
Okay, hypovolemic. The name itself gives a clue, right? Hypo, meaning low, volemic, referring to volume. So just not enough blood or fluid volume.
Precisely. It's caused by a severe depletion of fluid volume inside the blood vessels.
Like bleeding.
Yeah, it can be from obvious bleeding, like a major trauma, or severe internal hemorrhage from something like a ruptured abdominal aortic aneurysm, or even an ectopic pregnancy. But and this is important, it's not always blood loss. It can also stem from extreme fluid losses. Think severe burns, relentless vomiting or diarrhea, or even conditions like pancreatitis or severe sepsis, where fluids just leak out of the vessels into the tissues.
Right, so the tank is just running empty one way or another.
Yeah.
How does the body respond internally to that? What does that hemodynamic profile look like?
Okay, so in hypovolemic shock, your heart races, trying to compensate that tachycardia.
Trying to pump harder or faster?
Faster mainly. Though, interestingly, about 1/3 of acute blood loss patients, or maybe those on beta blockers, might paradoxically show a slower heart rate. It's a bit of a curveball.
Huh.
But the key thing is the amount of blood your heart pumps out each minute. The cardiac output, it plummets. And because there's so little fluid returning to the heart, the pressures inside the heart chambers before they pump what we call ventricular filling pressures, or preload, are critically low.
Makes sense. Not much coming back in.
Exactly. And the body's natural response: squeeze the blood vessels really tight. That increases systemic vascular resistance, or SVR, trying to keep the remaining blood pressure up and direct flow to vital organs. This intense squeezing also narrows the pulse pressure. That's the difference between your top and bottom blood pressure numbers. And crucially, because your tissues are desperate for oxygen, they extract every last bit they can get. So the oxygen level in the blood returning to the heart, the SvO2, will be very, very low.
And what would you literally see if you were looking at a patient? What are the physical signs?
You'd observe classic signs: low blood pressure, often systolic, below 90 millimilli Hg. Their mental state might be altered, maybe confused or lethargic, and their peripheral perfusion would be poor, meaning pale, clammy, cool hands and feet, as blood is diverted away from the skin to the core organs.
Okay.
Urine output would drop significantly, less than 50 millivillus per hour usually, and breathing would be rapid tachypnea. Oh, and a very specific sign for hypovolemic shock is flat, non-distended jugular veins in the neck. There's just not enough volume to fill them up.
Got it. Flat neck veins. Okay, now let's pivot to distributive shock. This sounds like a completely different kind of problem with the body's plumbing system.
In many ways, it is the opposite. The primary issue here isn't a lack of volume, it's a profound loss of peripheral vascular tone.
So the pipes are too loose.
Exactly. Imagine your blood vessels suddenly becoming these wide-open highways. Your existing blood volume just can't adequately fill that vastly expanded container.
And what causes that?
The most common forms include septic shock, which is due to an overwhelming infection. Then there's neurogenic shock, often from a spinal cord injury, and anaphylactic shock from a severe allergic reaction. Other causes can include things like an adrenal crisis or certain drug overdoses.
So the pipes are wide open, blood pressure drops, and blood can't get back efficiently.
Precisely. Hemodynamically, you'll often still see an increased heart rate, although, importantly, neurogenic shock can be an exception, sometimes presenting with a slow heart rate, bradycardia.
Okay, another exception to watch for.
Right. And what's distinct here is that cardiac output can actually be normal or even increased initially, especially if the patient has received enough fluids. But it will eventually drop if volume isn't optimized. Ventricular filling pressures can be low to normal, but the absolute hallmark is a significantly decreased systemic vascular resistance. That SVR is low because of the widespread vasodilation.
Makes sense. The vessels are relaxed.
Which often leads to a wider pulse pressure, unlike hypovolemic. And here's a really crucial insight, often surprises people. In distributive shock, your oxygen saturation in the venous blood, that SvO2, might actually look normal or even high.
Wait, high? How can that be if the body needs oxygen?
It's counterintuitive, isn't it? But it's a deceptive red flag. It means the tissues aren't using the oxygen effectively. Maybe blood is shunting past the capillary beds too quickly, or the cells themselves can't use the oxygen properly, like in sepsis. That's a critical difference from hypovolemic shock, where the tissues are extracting more oxygen.
Wow, okay, that's a huge difference. And how would the patient present physically?
Well, one key differentiator, especially in someone who's received fluids, is their extremities can actually feel warm to the touch.
Warm, not cold and clammy.
Right, warm initially due to that vasodilation. This is unlike the cool extremities you typically see in hypovolemic or cardiogenic shock. You'll still see the low blood pressure, rapid heart rate usually, altered consciousness, signs of poor organ perfusion, low urine output, and rapid breathing. But the potentially warm extremities and that wide pulse pressure are often telling signs.
And maybe fever.
Yes, fever might be present, particularly in septic shock or an adrenal crisis.
Okay. Then there's cardiogenic shock. This one sounds like the heart itself is the direct problem. The pump is failing.
That's spot on. The primary cause is a fundamental problem with the heart's pumping ability. It just can't generate enough cardiac output to deliver sufficient oxygen.
What usually causes that?
Most often it's triggered by a massive myocardial infarction, a big heart attack. But it can also result from severe arrhythmias, like a very fast or very slow heart rhythm, a failing heart valve, or inflammation of the heart muscle, myocarditis. And our sources also highlight that while they are technically obstructive causes, conditions like cardiac tamponade, a large pulmonary embolism, or tension pneumothorax, can definitely stress the heart so much they lead to a cardiogenic picture.
So the pump itself is just failing to do its job effectively.
Precisely. Hemodynamically, the heart rate typically increases as it tries desperately to compensate, but cardiac output plummets anyway. Critically, unlike hypovolemic shock, the ventricular filling pressures are increased.
By increased.
Because the heart isn't effectively pumping blood forward, so blood backs up into the heart and the lungs. Systemic vascular resistance also increases due to that compensatory vasoconstriction. The body trying to maintain pressure and pulse pressure decreases, similar to hypovolemic shock.
And the venous oxygen level.
That SVO2 will also significantly decrease, just like in hypovolemic shock, because of the poor overall oxygen delivery to the body's tissues.
What are the telltale physical signs for this type? What would you see?
You'll often see distended jugular veins in the neck. Those neck veins are bulging because of that increased pressure backing up from the heart. Pulmonary edema, fluid accumulating in the lungs, is very common, causing severe shortness of breath, and you might hear crackles when listening to the lungs.
Anything else?
A doctor might hear an extra heart sound called an S3 gallop. And, of course, the general signs of shock are there. Low blood pressure, altered consciousness, poor peripheral perfusion, cool, clammy skin, low urine output, and rapid breathing. It's a grim situation. The mortality, especially after a heart attack, can tragically be over 50%.
That's incredibly high. Okay, and finally, obstructive shock. This seems pretty straightforward. Something is literally blocking the blood flow.
It is, very literally. It's caused by a physical blockage of blood flow that either prevents the heart from filling properly or creates an overwhelming resistance for the heart to pump against.
Like what kind of blockages?
Classic examples include a massive pulmonary embolism, where a large blood clot gets lodged in the pulmonary arteries, blocking blood flow to the lungs. Or a tension pneumothorax, where trapped air collapses a lung and puts crushing pressure on the heart and great vessels. Or cardiac tamponade, where fluid rapidly builds up in the sac around the heart, squeezing it and preventing it from filling and pumping effectively.
How does that look on the inside, hemodynamically speaking?
Well, the heart rate typically increases, trying to overcome the obstruction. And predictably, cardiac output drops significantly. Ventricular filling pressures can actually vary. Sometimes they're increased, sometimes normal. It depends on the exact cause. For instance, in a massive PE, they might be normal or even low initially.
Interesting. And resistance.
Systemic vascular resistance can be increased or normal, and pulse pressure usually decreases. The venous oxygen saturation, SVO2, can be decreased or normal.
And the physical clues for obstructive shock.
You'll frequently see distended jugular veins, much like in cardiogenic shock, though they might be absent if the patient is also hypovolemic, perhaps from trauma causing the pneumothorax.
Okay.
A very specific sign for cardiac tamponade is something called pulsus paradoxus. That's where the systolic blood pressure drops significantly, more than 10 millimole Hg when the patient breathes in.
Wow. Specific.
It is. And for a tension pneumothorax, a tracheal shift where your windpipe visibly moves to one side, that's a very late and very grave sign. And as with all shock types, you'll see the general signs. Low blood pressure, altered mental status, poor peripheral circulation, low urine output, and rapid, shallow breathing.
So given all these different types and pathways, what does it all mean for someone experiencing shock? What are the immediate steps, the long-term goals? It sounds like rapid action is just the absolute core principle.
It truly is. The general principles of management are all designed for immediate impact and follow a very strict prioritization. First, it's about prompt recognition, spotting those signs of shock and physiological compromise as early as possible. Then, we immediately apply the classic ABCDE approach. Airway, breathing, circulation, disability, and exposure.
The ABCs first.
Always. For the airway, you have to ensure it's clear and open. Use airway adjuncts if needed. If consciousness is declining or breathing is severely distressed, you have to consider early intubation to protect the airway. But critically, manual bag mask ventilation with 100% oxygen is always preferred over prolonged, unsuccessful intubation attempts. You don't want delays.
Right.
In very specific severe cases, like anaphylaxis, where the airway is swelling shut, intramuscular epinephrine can rapidly reverse that obstruction. Or in extreme emergencies, a surgical airway like a cricothyrotomy might be life-saving.
Okay, airway secured. What about breathing and circulation?
For breathing, immediately administer supplementary oxygen. The goal is to keep oxygen saturation high, typically between 94 and 98%. It's also important to avoid excessive ventilation, usually aiming for about 10-12 breaths per minute. Too much pressure inside the chest can actually squeeze the heart and decrease cardiac output.
Oh, okay. Less is more sometimes.
In a way, yes. For circulation, you need immediate wide-bore IV access. 2 large peripheral IV lines are the standard preference. If you can't get IV access quickly, intraosseous IO access directly into the bone marrow is a rapid alternative for fluids and meds.
Wow, IO. That sounds intense, but effective.
It can be life-saving when seconds count, and you absolutely need continuous monitoring. Blood pressure, ideally with an arterial catheter for real-time readings, heart rate and heart rhythm via ECG.
What about tests?
Beyond the ABCDEs, immediate investigations include drawing blood samples, glucose, electrolytes, kidney function, full blood count, lactate levels, blood gas, coagulation screen. A 12-lead ECG and a portable chest X-ray are also immediate priorities. And monitoring urine output with a urinary catheter gives vital information about kidney perfusion and how well resuscitation is going.
So the overall goal is to stabilize them, right? But what are the specific targets? How do you know if you're actually succeeding in reversing the shock?
Right, the goals of resuscitation are clear and measurable. We want to restore hemodynamic stability, improve oxygen delivery to the tissues, and reverse those signs of hypoperfusion we talked about. Specifically, we aim for a mean arterial pressure, or MAP, greater than 65 mmHg, or you could think of it as a systolic BP above 90 mmHg. Urine output should be above 0.5 milliliters per kilogram per hour.
And lactate. You mentioned that's important.
Hugely important. We want to see lactate concentrations normalizing or decreasing. That's a powerful indicator that oxygen balance is improving at the cellular level. And of course, we look for improved mental status and improved capillary refill time as signs of better perfusion.
Okay, now let's really get into the specifics. Knowing the exact type of shock truly changes the game for treatment, doesn't it? You said it's not a one-size-fits-all solution.
Absolutely not. While those general principles apply to everyone initially, the specific management is entirely tailored to the underlying cause. Let's take hypovolemic shock again.
Right, the low-volume one.
The initial and most critical therapy is rapid expansion of that intravascular volume. Crystalloids, like 0.9% saline or preferably Ringer's lactate, are the go-to fluids. They're given in carefully titrated boluses for adults, typically 500 to 1,000 milliliters at a time, repeated as needed based on response.
Any caveats?
Yes, you do need to exercise some caution in elderly patients, pregnant individuals, or those with known heart or kidney failure, as they might not tolerate large fluid volumes as well.
And if the cause is massive blood loss, not just fluid loss?
If there's significant bleeding or severe anemia, then packed red blood cells are indicated. In profound, life-threatening shock, O-negative blood, the universal donor type can be given immediately while waiting for type-specific blood.
Okay.
For truly massive blood loss, like in major trauma, a balanced resuscitation approach is often recommended now, giving packed red blood cells, platelets, and fresh frozen plasma in a 1-to-1-to-1 ratio to mimic whole blood.
And stopping the bleeding itself.
Absolutely paramount. Hemorrhage control is key. Direct pressure for external wounds, tourniquets if appropriate for limb hemorrhage, or rapid surgical intervention for internal bleeding. And here's that interesting point again from our sources. In trauma patients without a traumatic brain injury who are bleeding internally and need surgery, doctors might consider permissive hypotension.
Right, keeping the BP a bit lower on purpose.
Exactly, intentionally keeping the systolic blood pressure around 90 to 100 mmHg temporarily. It sounds counterintuitive, but it can potentially save lives by preventing the disruption of newly formed clots before the surgeon can fix the source of bleeding.
Fascinating. Any medications?
Tranexamic acid, or TXA, given early, ideally within 3 hours of injury, can help stabilize clots and reduce bleeding. Vasopressors, drugs that constrict blood vessels, are generally only used as a temporary bridge to surgery, or if hypotension stubbornly persists despite adequate volume replacement in hemorrhagic shock. You need to fill the tank first.
Makes sense. Okay, moving on to distributive shock, with septic shock being the big one here. What's the immediate action plan?
With septic shock, there are two absolute priorities that need to happen almost simultaneously: source control and antibiotics. Find and treat the infection, drain an abscess, remove infected tissue, whatever is needed. And broad-spectrum antibiotics must be given as quickly as possible, ideally within 1 hour of recognition.
1 hour. That's fast.
It has to be. Every hour delay increases mortality significantly. Alongside that, early, aggressive volume resuscitation with isotonic crystalloids is crucial. Often, very large volumes are needed in sepsis because the vessels are so leaky. Ringer's lactate is generally preferred over normal saline in large volumes.
What if fluids aren't enough to bring the pressure up?
That's when vasopressors become necessary to squeeze those dilated vessels and maintain perfusion pressure. Norepinephrine is usually the first choice vasopressor in septic shock.
Others?
Epinephrine can be used if the response to norepinephrine is inadequate. Vasopressin can be added as an adjunct. It works differently. Dopamine is an alternative, but it carries a higher risk of causing heart rhythm problems, so it's often avoided if other options are available.
What about steroids?
For septic shock that remains hypotensive despite adequate fluids and high doses of vasopressors, what we call refractory shock, intravenous hydrocortisone may be considered.
And quickly, for the other distributive causes like anaphylaxis.
Anaphylactic shock is a true medical emergency treated primarily with intramuscular epinephrine. That's the absolute first-line treatment. Along with that, IV crystalloids, antihistamines, and corticosteroids are given.
Neurogenic.
For neurogenic shock from spinal cord injury, the treatment involves volume resuscitation and vasopressors, often phenylephrine or norepinephrine. Atropine or dopamine might be needed to treat a slow heart rate if it occurs. And interestingly, the mean arterial pressure goal is often kept higher in spinal cord injury, maybe above 85 mmHg, to ensure adequate perfusion to the injured cord.
And adrenal crisis.
Adrenal crisis requires prompt volume therapy, immediate high-dose IV corticosteroids like hydrocortisone, and potentially vasoactive medications if needed.
Okay, then there's cardiogenic shock, where the heart pump itself is failing. What's the focus there?
Here, the primary goals are to improve the heart's pumping function and, crucially, treat the underlying cause. If it's a heart attack causing the shock, the definitive treatment is immediate reperfusion, opening up the blocked coronary artery, usually via percutaneous coronary intervention or PCI in a cardiac cath lab.
Time is muscle, right?
Exactly. Time is heart muscle. Fluid management has to be very cautious here. We often give fluids in small, careful boluses, maybe 250 ml at a time, while closely watching for signs of fluid overload, like worsening shortness of breath or crackles in the lungs, because the failing heart can easily get overwhelmed and cause pulmonary edema.
What about drugs to help the heart pump?
Yes, we use inotropes medications that increase the heart's contractility. Dobutamine is frequently used. Milrinone is another option, though it can cause more vasodilation and lower blood pressure. Levosimendan is used in some places.
And if the blood pressure is dangerously low?
If the patient is severely hypotensive, say systolic pressure below 70 mmHg, then a vasopressor like norepinephrine or dopamine might be used concurrently to rapidly raise blood pressure and maintain organ perfusion while other treatments take effect.
Any other options for severe cases?
For patients who don't respond to medications, advanced mechanical circulatory support might be necessary. This includes devices like an intra-aortic balloon pump, IABP, or even ventricular assist devices, VADs, which essentially take over some of the work of the failing heart.
Wow, complex stuff. And lastly, obstructive shock. You mentioned the key is removing that physical blockage.
Precisely. Relief of the obstruction is the primary treatment, and it needs to happen fast. For a tension pneumothorax, that means prompt needle decompression in the field or ER to release the trapped air, followed quickly by inserting a chest tube.
Immediate relief.
Yes. For cardiac tamponade, performing a pericardiocentesis, inserting a needle into the sac around the heart to drain the compressing fluid, can be immediately life-saving.
And for a massive PE.
With a massive pulmonary embolism causing obstructive shock, maintaining intravascular volume with careful fluid resuscitation is important initially. Prompt anticoagulation with heparin is vital, but the definitive treatments involve either thrombolytic therapy clot-busting drugs or performing a thrombectomy, which is physically removing the clot, either via catheter or surgery. These are usually reserved for patients with refractory shock or those nearing cardiac arrest.
Do fluids and pressors help much here?
While maintaining volume is important, fluids might only provide temporary improvement. Inotropes and vasopressors generally play only a minimal supportive role in obstructive shock because they don't fix the underlying mechanical problem. The obstruction has to be relieved.
Okay, you mentioned diagnosis, and I know this tool is becoming a real game changer in emergency settings, offering instant insights. How does point-of-care ultrasound, or POCUS, become such a superpower for doctors in these critical moments?
POCUS is rapidly becoming just indispensable at the bedside for quick diagnosis and guiding management in shock. It's incredibly powerful.
How so? For which types?
Okay, for suspected hemorrhagic shock, doctors can perform what's called an EFAST exam that stands for Extended Focused Assessment with Sonography for Trauma.
EFAST. Okay.
It's a standardized, quick ultrasound scan performed right at the bedside. It can instantly show if there's free fluid, which is usually blood in trauma, in key areas like the abdomen around the organs, in the chest cavity, or around the heart. It gives immediate clues about internal bleeding.
So you can see the bleeding almost.
You can see the result of the bleeding, the free fluid accumulating. POCUS can also visualize the heart itself, often showing a small, hyperdynamic, rapidly beating heart and a collapsed or flat inferior vena cava, the large vein returning blood to the heart, both signs strongly suggesting low volume.
So you can literally see the fluid status and potential internal bleeding in real time. That's incredible.
It truly revolutionizes the initial assessment. For suspected cardiogenic shock, a quick bedside echocardiogram, part of POCUS, can identify a dilated, poorly contracting left ventricle, specific wall motion abnormalities suggesting a heart attack, problems with heart valves, or even fluid around the heart indicating cardiac tamponade is the cause.
Wow. And for obstructive?
In obstructive shock, POCUS is again incredibly powerful for pinpointing the specific blockage. For a massive pulmonary embolism, the echo might reveal a severely dilated and struggling right ventricle, indicating acute right heart strain.
Okay.
For a tension pneumothorax, a quick look at the lungs with ultrasound can show the absence of lung sliding, a very specific sign that the lung is collapsed and air is trapped in the chest cavity. And for cardiac tamponade, the ultrasound view from just below the ribs, the subxiphoid view, clearly shows that characteristic anechoic or black fluid collection compressing the heart.
So it can really differentiate those obstructive causes quickly. What about sepsis?
Yes, POCUS is also a key component of protocols like the RUSH exam. Rapid ultrasound for shock and hypotension, often used for undifferentiated shock, including suspected septic shock. This exam includes structured views of the heart, the pump, the IVC, the tank, the lungs, looking for things like pulmonary edema or pneumonia, and the abdominal aorta, ruling out an aneurysm. It helps assess cardiac function, estimate fluid status, and look for potential sources of infection or other causes of shock.
It really sounds like a vital tool. Okay, so we're giving fluids, maybe blood, we're giving medications like vasopressors. How do medical teams know if their treatments are actually working?
Right.
Or if they need to change course immediately? It's not just about starting treatment, right? It's constant adjustment.
That's the absolute art and science of resuscitation. Fluid responsiveness is often the initial therapy for many forms of shock, but it absolutely must be titrated with frequent reassessments. You don't just hang a bag and walk away.
How do you assess?
Well, a rapid improvement in blood pressure or perfusion after a fluid bolus often strongly suggests hypovolemic shock. If the response is only transient, lasting just a few minutes, it might signal ongoing bleeding that needs controlling. And if there's no response at all, particularly in trauma, it might indicate the need for immediate blood products and likely surgical intervention.
Are there better ways than just watching the BP?
Yes, increasingly dynamic parameters are used. Our sources emphasize that looking at things like the respiratory variation in the diameter of the inferior vena cava using POCUS, or analyzing the pulse pressure variation during mechanical ventilation are generally better indicators of whether a patient will actually benefit from more fluids compared to static measures like just looking at the central venous pressure, CVP number.
Why is being careful with fluids so important?
Because fluid overload can be really detrimental, especially in cardiogenic shock where the heart is already struggling, or even in septic patients where their capillaries or leaky excess fluid can just pour into the lungs and tissues, worsening oxygenation. So we carefully monitor for signs of overload like new lung crackle, worsening oxygen levels, or increasingly distended neck veins.
Okay, and with vasopressors, those powerful drugs, how are they managed to get just the right effect without causing harm?
Vasopressors, like norepinephrine or epinephrine, are used either to constrict blood vessels, increasing SVR, or sometimes to increase the heart's contractility. Inotropes like dobutamine fit here, too. They're indicated when blood pressure is dangerously low or remains low, despite what seems like adequate fluid resuscitation.
And the choice depends on the type of shock.
Absolutely. The choice depends heavily on the desired hemodynamic effect and the specific shock type. As we said, norepinephrine is often preferred for the vasodilation of septic shock. Epinephrine is the non-negotiable first choice for anaphylactic shock. Phenylephrine might be used in neurogenic shock. They generally have a minimal role in obstructive shock, and crucially, they must be used with extreme caution in hypovolemic shock until adequate volume is replaced. Giving pressors to a patient with an empty tank can actually worsen tissue perfusion.
So you titrate them carefully.
Meticulously. We titrate the infusion rates continuously, adjusting them up or down to maintain specific blood pressure goals, like that mean arterial pressure, greater than 65 mmHg, while constantly reassessing the patient's overall perfusion status.
And beyond the numbers on the monitor, the blood pressure, the heart rate, what are the ultimate signs that all these efforts are making a real difference? That the patient is truly improving?
That's a great question. Beyond just the vital signs, we pay incredibly close attention to the lactate concentration. A decreasing or normalizing lactate level is a vital sign that resuscitation is adequate at the cellular level. It's actually highly predictive of survival.
So lactate tells you if the tissues are getting enough oxygen again.
In essence, yes. It reflects the balance between oxygen delivery and consumption. High lactate means tissues aren't getting enough oxygen and are resorting to anaerobic metabolism. Seeing that number come down is a very good sign. Long term, of course, we also monitor for the normalization of organ function, things like improving kidney function reflected in urine output and creatinine levels, or improving liver function tests. It really is a process of continuous reassessment, looking at the whole picture, not just one number.
We've just navigated this really intricate landscape of clinical shock syndromes. It's quite something. From their distinct causes, how they manifest inside the body, all those hemodynamic changes, to the precise, time-critical emergency management strategies.
A lot to cover.
It is. And understanding these nuances, the difference between, say, a body struggling from a lack of volume versus a heart that just can't pump effectively, it really underscores how discerning those differences can literally mean the difference between life and death. The information we've explored today truly highlights the incredible complexity and the vital importance of swift, targeted intervention.
It really does. And, this raises an important question, I think. In a world where information, especially health information, can often feel overwhelming or confusing, how might understanding the specific, detailed differences in conditions like shock empower you, the listener? Not just to grasp complex medical concepts, maybe, but also to critically evaluate health information you come across, and perhaps even advocate more effectively for precise care, whether it's for yourself or for others.
That's a truly powerful thought to consider, how understanding the specifics empowers you. Well, thank you for joining us on this deep dive into clinical shock. We really hope you feel more informed, perhaps a bit more empowered by this knowledge, and ready to continue your journey of understanding.